Lewis's Medical Surgical Nursing, 11th edition, Chapter 40, Obesity. Obesity is an excessively high amount of body fat or adipose tissue. Obesity is a global problem because it is a major risk factor for leading causes of death, including type 2 diabetes, heart disease, and certain cancers. Overweight persons often have a number of other problems, such as problems with mobility and sleeping, that affect health. The consequences of obesity extend beyond the physical changes. Social stigma can take an emotional toll on a person's psychologic well-being. Many have problems related to altered body image, depression, and low self-esteem, and withdraw from social interaction. Attitudes about obesity can create biases and discrimination against people who are obese. Obesity must be viewed and treated as a chronic disease similar to other chronic diseases such as diabetes and hypertension. Epidemiology of obesity. The obesity problem is a public health crisis. After decades of rising obesity rates among adults, the rate of increase is beginning to slow, but rates are still far too high. Currently, about 40% of adults in the United States are obese. Significant geographic, racial, and ethnic and income disparities exist. Obesity rates are highest in the South and among Blacks, Hispanics, and lower income, less educated Americans. Obesity in adulthood is often a problem that begins in childhood or adolescence. 1 in 10 children becomes obese as early as age 2 to 5. Reversing the childhood obesity crisis is key to addressing the overall obesity epidemic. Etiology and Pathophysiology. Obesity is an increase in body weight beyond the body's physical requirements. This results in an abnormal increase in accumulation of fat cells. However, the processes leading to and sustaining the obese state are complex and still undergoing investigation. In obesity, there is an increase in the number of adipocytes, hyperplasia, and an increase in their size, hypertrophy. Adipocyte hypertrophy is a process by which adipocytes can increase their volume several thousand times to accommodate large increases in lipid storage. When storage of existing fat cells is exceeded, pre-adipocytes are triggered to become adipocytes. This process occurs primarily in the visceral, intra-abdominal, and subcutaneous tissues. The process of hyperplasia of adipocytes is greatest from infancy through adolescence. Most obese persons have primary obesity, which is excess calorie intake over energy expenditure for the body's metabolic demands. Others have secondary obesity, which can result from various congenital anomalies, chromosomal anomalies, metabolic problems, central nervous system (CNS) lesions, and disorders or drugs, e.g. corticosteroids, antipsychotics. The cause of obesity involves genetic and biologic factors that are influenced by environmental and psychosocial factors. While each of these factors can and should be considered individually, in reality, they are interrelated. Genetic link. A genetic predisposition to obesity may be present in as many as 70% of those who are obese. Several genes that are linked to obesity have been found. Genes appear to influence how calories are stored and energy released. Energy-thrifty genes, once protective against long periods when food was not available, are now maladaptive in societies in which food availability is no longer an issue. Genes may be responsible for why 2 people living in the same environment can vary considerably in body size. A strong link exists between a gene known as FTO, fat mass and obesity associated gene, and body mass index, BMI. Variants of this gene may explain why some people become overweight while others do not. People with a certain allele of the FTO gene appear to have an increased appetite, reduced satiety, and higher caloric intake. More research is needed to better understand the role of genes in obesity. Physiologic regulatory mechanisms in obesity. Research has focused on the physiologic regulatory processes that control eating behavior, energy metabolism, and body fat metabolism. Knowing how appetite is triggered and energy is spent gives important information for understanding obesity and specific targets for the development of drugs. The hypothalamus, gut, and adipose tissue synthesize hormones and peptides that stimulate or inhibit appetite. The hypothalamus is a major site for regulating appetite. Neuropeptide Y, made in the hypothalamus, is a powerful appetite stimulant. When it is imbalanced, it leads to overeating and obesity. Hormones and peptides made in the gut and adipocyte cells affect the hypothalamus, have a critical role in appetite and energy balance. When overeating develops at an early age and continues into adulthood, one's ability to sense fullness, satiety, is altered. Leptin, secreted from adipocytes when they fill with fat, acts in the hypothalamus to suppress appetite and increase fat metabolism. A genetic deficiency of leptin causes extreme obesity. However, most obese persons have high leptin levels, suggesting that they are leptin resistant. This may be due to a failure to make enough leptin receptors or producing faulty receptors. Ghrelin, a gut hormone, regulates appetite by inhibiting leptin. It acts in the hypothalamus and the brain's pleasure centers to stimulate hunger. In a non-obese person, ghrelin levels are higher when a person is hungry and decrease in response to eating. Ghrelin is thought to play a part in compulsive eating. Low ghrelin levels after gastric bypass surgery helps suppress appetite. The two major consequences of obesity are due to the sheer increase in fat mass and production of adipokines made by fat cells. Adipocytes make at least 100 different proteins. These proteins, secreted as enzymes, adipokines, growth factors, and hormones, contribute to insulin resistance, dyslipidemia, and high blood pressure. Excess visceral fat is associated with more alterations of adipokines. This causes people with abdominal android obesity more complications of obesity. An increased release of cytokines from fat cells may disrupt immune factors and predispose the person to certain cancers. Environmental factors. Environmental factors play a key role in obesity. In today's culture, people have greater access to food, particularly prepackaged and fast foods, and soft drinks, which have poor nutritional quality. In addition, eating outside of the home interferes with the ability to control the quality and quantity of food. Portion size of meals has increased dramatically. Underestimating portion sizes and therefore caloric intake is common. Lack of physical exercise is another factor that contributes to weight gain and obesity. With increases in the use of technology, labor-saving devices, and cars, we expend less energy in our everyday lives. Elimination of physical education programs in schools, along with increased time spent playing video games and watching TV, has contributed to the increase of sedentary habits. Socioeconomic status is a known risk factor for obesity in a variety of ways. People with low incomes may try to stretch their food dollars by buying less expensive foods that often have poor nutritional quality with a greater caloric content. For example, people with low incomes are more likely to buy pasta, bread, and canned fruit packed with sugar rather than chicken and fresh fruits and vegetables. Low-income residents may live in environments that do not accommodate outdoor activities, e.g., safe playgrounds, walking tracks, tennis, swimming pools. Psychosocial factors. People use food for many reasons besides its nutritional value. Associations with food begin in childhood, such as the use of food for comfort or rewards. The social component of eating begins early in life when food is associated with pleasure and fun at such events as birthday parties, Thanksgiving, and religious holidays. Mindless eating refers to eating more than one normally would because of outside factors. These factors include the food's presentation and eating while distracted, such as when studying or watching television. Mindless eating leads to consuming unnecessary calories and an increase in body weight. Health risks associated with obesity. Hippocrates wrote that corpulence is not only a disease itself, but the harbinger of others, thus recognizing that obesity has major adverse effects on health. Many problems occur in obese people at higher rates than in people of normal weight. Mortality rates rise as obesity increases, especially when obesity is associated with visceral fat. In addition to these problems, obese patients have a reduced quality of life. Fortunately, most of these conditions can improve if a person loses weight. Cardiovascular problems. Obesity is a significant risk factor for cardiovascular disease, CVD, and stroke in both men and women. Android obesity is the best predictor of these risks and is linked with increased low-density lipoproteins, LDLs, high triglycerides, and decreased high-density lipoproteins, HDLs. Hypertension can occur because of increased circulating blood volume, abnormal vasoconstriction, increased inflammation, damaging blood vessels, and increased risk for sleep apnea raises BP. Excess body fat can lead to chronic inflammation throughout the body, especially in blood vessels, thus increasing the risk for heart disease. Diabetes. Obesity is a major risk factor for the development of type 2 diabetes. Hyperinsulinemia and insulin resistance, common features of type 2 diabetes, are also found in obesity. The term diabesity reflects the combined effects of diabetes and obesity. Excess weight decreases the effectiveness of insulin. When insulin does not work effectively, too much glucose stays in the bloodstream. Thus, more insulin is made to compensate. Pancreatic beta cells, cells that make insulin, may get overworked and become worn out. Over time, the pancreas is no longer able to keep blood glucose in normal range. Adiponectin, a peptide that increases insulin sensitivity, is decreased in obese people. Obesity complicates the management of type 2 diabetes by increasing insulin resistance and glucose intolerance. These factors make drug treatment for diabetes less effective. Gastrointestinal and liver problems. Gastroesophageal reflux disease, GERD, and gallstones are more prevalent in obese people. Gallstones occur due to supersaturation of the bile with cholesterol. Non-alcoholic steatohepatitis, NASH, is a condition in which lipids are deposited in the liver, resulting in a fatty liver. NASH is associated with increased hepatic glucose production. NASH can eventually progress to cirrhosis and can be fatal. Weight loss can improve NASH. Respiratory and sleep problems. The increased fat mass associated with obesity may lead to sleep apnea and obesity hypoventilation syndrome. The increased distribution of fat around the diaphragm causes reduced chest wall compliance, increased work of breathing, and decreased total lung capacity. Sleep apnea results from increased fat around the neck, leading to snoring and hypoventilation while sleeping. Weight loss can improve lung function. Poor sleep and sleep deprivation may increase appetite. Sleep deprivation has been associated with obesity. Building up a sleep debt over a matter of days can impair metabolism and disrupt hormone levels. The level of leptin falls in people who are sleep deprived, thus promoting appetite. Musculoskeletal problems. Obesity is associated with an increased incidence of osteoarthritis because of the stress put on weight-bearing joints, especially the knees and hips. Increased body fat also triggers inflammatory mediators and contributes to deterioration of cartilage. Hyperuricemia and gout often occur in people who are obese and those who have metabolic syndrome, discussed later in this chapter. Cancer. Obesity is one of the most important preventable causes of cancer. Types of cancer most strongly linked to excess body fat are thyroid, liver, kidney, colorectal, breast, endometrial, and gallbladder cancer. The underlying mechanisms linking obesity and cancer remain unclear. Breast and endometrial cancer may be due to the increased estrogen levels, estrogen is stored in fat cells, associated with obesity in postmenopausal women. Colorectal cancer has been linked to hyperinsulinemia. Esophageal cancer may be related to acid reflux caused by abdominal obesity. Several hormones and factors often present in obese states increase the risk for cancer. For example, insulin, a powerful cellular growth factor, is increased in obesity. The resulting hyperinsulinemia may affect cancer cells. Adipokines from fat cells may stimulate or inhibit cell growth. For example, leptin, which is increased in obese people, promotes cell proliferation. Metabolic syndrome. Metabolic syndrome is one of the fastest growing obesity health concerns, as discussed later in this chapter, page 885. Psychosocial problems. The consequences of obesity extend beyond the physical changes. Stigmatization of obese people, and in some cases, discrimination, occurs in three important areas of living: employment, education, and healthcare. The social stigma associated with obesity has an emotional toll on a person's psychological well-being. Many obese persons have low self-esteem, withdraw from social interaction, and have major depression. Nursing and interprofessional management, obesity. Nursing assessment. The first step in the treatment of obesity is to determine whether any physical conditions are present that may be causing or contributing to obesity. This requires a thorough history and physical examination. Before you begin, examine your own personal beliefs and any potential biases related to obesity. If you associate obesity with a lack of willpower and overindulgence, you may convey your attitude to patients. They may experience shame in a setting that claims to be a caring one. When assessing a person who is overweight or obese, be sensitive and non-judgmental in asking specific and leading questions about weight, diet, and exercise. In doing so, you can often obtain information that the patient may have withheld out of embarrassment or shyness. Patients need to understand the reason for questions asked about weight or dietary habits. You must be ready to respond to their concerns. Assess the patient's willingness to change and potential for change. If people are not ready for change, offer them the opportunity to return for further discussion when they are ready to discuss their weight again and make lifestyle changes. When obtaining the history, explore genetic and endocrine factors such as hypothyroidism, hypothalamic tumors, Cushing's syndrome, hypogonadism in men, polycystic ovary syndrome in women. Laboratory tests of liver function and thyroid function, a fasting glucose level, and a lipid panel, triglyceride level, LDL and HDL cholesterol levels, aid in evaluating the cause and effects of obesity. When no organic cause, e.g. hypothyroidism, is associated with obesity, the disorder should be considered a chronic complex disease. Assess for any comorbid diseases associated with obesity, e.g. hypertension, sleep apnea. These obesity-related complications require special treatment. As part of the initial nursing physical examination, Assess each body system with particular attention to the organ system in which the patient has expressed a problem or concern. Measurements used with the obese person may include height without shoes, weight obtained in a private location and in a gown if possible, waist circumference, and BMI. Have the right equipment to take these measurements. Provide special chairs, examination tables, and scales that can accommodate an obese person. Classifications of body weight and obesity. An important part of your patient assessment is to determine and classify a patient's body weight. Common assessment methods include BMI, waist circumference, waist to hip ratio, WHR, and body shape. The most widely used and endorsed measures are BMI and waist circumference. These measures are cost-effective, reliable, and easily used in all practice settings. Body mass index. The most common measure of obesity is the body mass index, BMI. BMI is calculated by dividing a person's weight in kilograms by the square of the height in meters. Table 40.5 shows a classification of overweight and obesity by BMI. Persons with a BMI less than 18.5 are considered underweight. A BMI between 18.5 and 24.9 reflects a normal body weight. BMI of 25 to 29.9 is classified as being overweight. Those with values at 30 or above are considered obese. The term extreme obesity, morbid or severe obesity, is used for those with a BMI greater than 40. Though BMI provides an overall assessment of fat mass, we must consider BMI in relation to the patient's age, gender, and body build. For example, a bodybuilder may have a BMI associated with obesity, but because of a high muscle mass, the BMI would not be an accurate assessment. In contrast, in those who have lost body mass, e.g. older adults, the BMI would underestimate the degree of obesity. For this reason, other measures must be combined with the BMI for an accurate evaluation of a person's weight. Waist circumference. Waist circumference is another way to assess and classify a person's weight. The average waist size has increased by more than 1 inch, from 37.6 inches to 38.8 inches, in the past decade. Health risks increase if the waist circumference is greater than 40 inches in men and greater than 35 inches in women. People who have visceral fat with android obesity have an increased risk for CVD and metabolic syndrome, discussed later in this chapter. Waist to hip ratio. The waist to hip ratio, WHR, is another method used to assess obesity. This ratio describes the distribution of both subcutaneous and visceral adipose tissue. Calculate the WHR by dividing the waist measurement by the hip measurement. A WHR less than 0.8 is best. A WHR greater than 0.8 indicates more truncal fat, which puts a person at a greater risk for health complications. Body shape. Body shape is another way of identifying those who are at a higher risk for health problems. People with fat primarily in the abdominal area, an apple-shaped body, have android obesity. Those with fat distribution in the upper legs, a pear-shaped body, have gynoid obesity. Genetics has an important role in determining a person's body shape and weight. Nursing diagnoses. Nursing diagnoses for the patient with obesity may include obesity, activity intolerance, impaired physical mobility, disturbed body image. Planning. The overall goals are that the obese patient will 1. Modify eating patterns, 2. Take part in a regular physical activity program, 3. Achieve and maintain weight loss to a specified level, and 4. Minimize or prevent health problems related to obesity. Nursing implementation. Obesity is one of the most challenging health problems. For most patients, successful weight management will be a hard, lifelong project. Obesity treatment begins with patients understanding their weight history and deciding on a plan that is best for them. It is rare to find an obese person who has not tried to lose weight. Some people have met with limited and temporary success, and others have met only with failure. You are in a key position to help obese patients by 1. Helping them explore and deal with their negative experiences, and 2. Teaching other health professionals about stigma and biases experienced by obese patients. Although healthcare for obese people has greater demands, HCPs often do not address these needs. HCPs are often reluctant to counsel patients about obesity for a variety of reasons, including 1. Time constraints during appointments make it hard. 2. Weight management may be viewed as professionally unrewarding. 3. Reimbursement for weight management services is hard to obtain. And 4. Many HCPs do not feel knowledgeable about giving weight loss advice. Despite knowing benefits of weight loss, most people find the process tough. Achieving an ideal BMI is not necessary and may not be a realistic goal. Modest weight loss of even 3 to 5% of starting weight can have clinical benefits, and greater weight losses produce greater benefits. In general, the average weight loss program, except for bariatric surgery, results in a 10% reduction of body weight. The average should not be considered a failure, since it is associated with significant health benefits. Exploring a person's motivation for weight loss is essential for overall success. Using principles for motivational interviewing, see Chapter 4, you can help patients understand their desire to lose weight and gain confidence in achieving weight loss. Focusing on the reasons for wanting to lose weight may help patients develop strategies for a weight loss program. Any supervised plan of care must be directed at 2 different processes. 1. Successful weight loss, which requires a short-term energy deficit, and 2. Successful weight control, which requires long-term behavior changes. Together with other members of the interprofessional care team, you have a key role in planning for and managing the care of an obese patient. A holistic approach for weight loss must be used that includes nutritional therapy, exercise, behavior modification, and for some, drugs or surgical intervention. Combining more than one aspect supports more effective weight loss and weight control efforts. While teaching patients, stress healthy eating habits and adequate physical activity as lifestyle patterns to develop and maintain. Nutritional therapy. There are no magic diets for weight loss. No one diet is superior for weight loss. All diets can work if they reduce caloric intake compared to expenditure and are one to which the patient will adhere. The ability to adhere to a diet and degree of weight loss strongly depends on the patient's motivation. Restricting dietary intake so that it is below energy requirements is a cornerstone for any weight loss or maintenance program. Table 40.8 presents an example of a 1200 calorie diet. It is best to recommend a dietary approach in which calorie restriction includes all food groups. In general, recommend a diet that includes adequate amounts of fruits and vegetables, gives enough bulk to prevent constipation, and meets daily vitamin A and vitamin C requirements. Lean meat, fish, and eggs provide sufficient protein and the B-complex vitamins. Patients will find it easier to incorporate such change into their lifestyle and not become as bored with their food options. A very low-calorie diet plan that limits calories to a total of 800 or less per day may be prescribed if rapid weight loss is needed. These diets are not sustainable on a long-term basis. They should be provided only by trained professionals in a medical care setting. Persons on very low-calorie diets need frequent professional monitoring because the severe energy restriction places them at risk for multiple health complications. Many people try to lose weight by following one of the many fad diets that offer the enticement of quick weight loss with little effort. Often these quick weight reduction diets, found in the popular media, advocate eliminating one category of foods, e.g. carbohydrates. Therefore, these should be discouraged. Low carbohydrate diets do produce a rapid weight loss, but reduce the ability to get adequate amounts of fiber, vitamins, and minerals. Restrictive diets are hard to maintain on a long-term basis. The more restrictive the diet, the greater the demand for intense discipline in the face of an intense desire to eat foods not allowed on the diet. The degree of success of any diet depends in part on the amount of weight to be lost. A moderately obese person will obviously reach a weight goal more easily than a person with extreme obesity. Because men have a higher percent of lean body mass, they are often able to lose weight more quickly than women. Women have a higher percent of body fat, which is metabolically less active than muscle tissue. Postmenopausal women are particularly prone to weight gain, especially increased abdominal fat. Setting a realistic and healthy goal, such as losing 1 to 2 pounds per week, should be mutually agreed on at the beginning of a weight loss program. Trying to lose too much too fast usually results in a sense of frustration and failure for the patient. You can help patients understand that losing large amounts of weight in a short period causes skin and underlying tissue to lose elasticity and tone. Slower weight loss offers better cosmetic results. Inevitably, the patient reaches plateau periods during which no weight is lost. These plateaus may last from several days to several weeks. Remind the patient that plateaus are normal occurrences during weight reduction. A weekly check of body weight is a good method of monitoring progress. Daily weighing is not recommended because of fluctuations that result from retained water, including urine and feces. Teach the patient to record the weight at the same time of the day, wearing the same type of clothing. There's no clear consensus on the number of meals a person on a diet should eat. Some advocate several small meals per day because the body's metabolic rate is temporarily increased right after eating. However, patients eating several small meals a day might consume more calories unless they carefully adhere to portion sizes, total daily calorie allotment. When a person first starts a weight loss program, food portion sizes must be carefully determined to stay within the dietary guidelines. Portion sizes over the past 40 years have increased considerably. Food portions can be weighed using a scale, or everyday objects can be used as a visual cue to determine portion sizes. The size of a woman's fist or a baseball is equivalent to a serving of vegetables or fruit. The recommended portion size of meat is 3 ounces. This is about the size of a person's palm or deck of cards. Serving of cheese is about the size of a thumb or 6 dice. Standard size for chopped vegetables is half a cup according to My Plate guidelines. A portion size quiz is available at blah 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 website. Another aspect of the American diet to consider is which foods contribute the most calories: animal sources, fruits, grains, or vegetables. 2/3 or more of a person's diet should be plant source foods, and the other 1/3 or less should be from animal protein. Being aware of personal consumption habits and striving for the 2/3 to 1/3 ratio is a simple goal that one can achieve without weighing and measuring foods at every meal. Once the ratio is part of meal planning, the patient can gradually reduce portions as they gradually increase activity levels to achieve healthy weight loss. A list of healthy or low-calorie foods serves as a good reference and allows the patient to dine out on occasion. Furthermore, the patient who carefully follows the prescribed diet may not need to take vitamin supplements. Encourage the appropriate fluid intake in the form of water. Alcoholic and sugary beverages should be limited or avoided since they increase caloric intake and are low in nutritional value. Exercise. Exercise is an essential part of a weight loss program. Patients should exercise daily, preferably 30 minutes to an hour, with a goal of more than 10,000 steps per day. There is no evidence that increased activity promotes an increase in appetite or leads to dietary excess. In fact, exercise has the opposite effect. The addition of exercise results in more weight loss than dieting alone has a favorable effect on body fat distribution. The type of exercise, e.g., high intensity versus low intensity, does not seem to affect overall weight loss. More intensive activity may result in weight loss with a reduced time commitment, making it preferable to some people. Exercise is especially important in supporting weight loss. Higher levels of physical activity, 200 to 300 minutes per week, are recommended to maintain weight loss or minimize weight regain in the long term. Explore ways to incorporate exercise in daily routines. It may be as simple as parking farther from their place of employment or taking the stairs versus an elevator. Encourage a person to use a pedometer to track progress toward meeting the 10,000 steps a day goal. However, success may be walking 1/3 of the recommended steps with incremental increases over time. Patients can swim and cycle, which both have long-term benefits. Joining a health club can be another way of getting exercise. Stress to patients and engaging in weekend exercise only, or in spurts of strenuous activity, is not helpful and can be dangerous. Behavior modification. The assumptions behind behavior modification are: 1. Obesity is a learned disorder caused by overeating, and 2. Often the critical difference between an obese person and a person of normal weight is the cues that regulate eating behavior. Therefore, most behavior modification programs de-emphasize the diet and focus on how and when to eat. Ideally, behavior intervention should begin with counseling sessions with a trained interventionist. Persons who are in a behavioral therapy program are more successful in maintaining their losses over an extended time than those who do not take part in such training. Various behavioral techniques for patients engaged in a weight loss program include: 1. Self-monitoring, 2. Stimulus control, and 3. Rewards. Self-monitoring may involve keeping a record of the type and time food was consumed, what the person was doing, and how the person was feeling when eating. By looking at the cues and events before eating, the person can identify areas in which to make behavior changes to break the chain of events and prevent overeating. These eating behaviors must be changed, or any weight loss will only be temporary. Stimulus control is aimed at eliminating cues in the environment that trigger eating. For example, if the patient overeats while watching television, limiting eating to a certain area, e.g. kitchen table, can be an effective way to weaken the link between eating and television watching. The more often the person does not eat in front of the television, less likely television watching will trigger overeating. Rewards may be incentives for weight loss. Short and long-term goals are useful benchmarks for earning rewards. It is important that the reward for a specified weight loss not be associated with food, such as dinner out or a favorite treat. Reward items do not need to have a monetary component. For example, time for a hot bath or an hour of pleasure reading will be an enjoyable reward for many people. Praise your patient's successes, even small ones, at every opportunity. Changing existing behaviors is hard. Support groups. People who are on a weight management plan are often encouraged to join a group in which others are trying to change their eating habits. Many self-help groups offer support and information on dieting tips. For example, Take Off Pound Sensibly, TOPS, is the oldest nonprofit organization of this type. Behavior modification is an integral part of the program, along with nutrition education. Weight Watchers International, Jenny Craig, and Nutrisystem are probably the most successful commercial weight loss programs. Weight Watchers offers a food plan that is nutritionally balanced and practical to follow. Group leaders, all of whom have successfully lost weight with Weight Watchers, teach members various behavior modification techniques. There are many commercial weight reduction centers. Most programs are staffed by nurses and dietitians. These weight reduction centers are cost prohibitive for those with limited financial resources. Most programs offer special prepackaged foods and supplements that a person must buy as part of the weight reduction plan. The person only consumes these prescribed foods and drinks until an agreed on amount of weight is lost. The person is encouraged to buy the same type of foods for the maintenance phase of the program, lasting from 6 months to 1 year. Behavior modification training is part of these programs. People must learn how to adjust their diet once they are no longer using the commercial products. This can be challenging for many. The person may regain weight lost once the restricted food program is completed. In recent years, many employers have begun weight loss programs at the workplace. The reason for such programs is that better health repays the cost of the programs through improved work performance, decreased absenteeism, less hospitalization, and lower insurance costs. Both employees and employers report benefiting from such programs. Drug therapy. Drugs should never be used alone. Rather, drugs should be part of a comprehensive weight loss program that includes reduced calorie diet, exercise, and behavior modification. They should be reserved for adults with a BMI of 30 or greater, obese, or adults with a BMI of 27 or greater, overweight, who have at least one weight-related condition, such as hypertension, type 2 diabetes, or dyslipidemia. There are currently 5 obesity drugs for long-term management approved by the FDA, Table 40.9. Appetite-suppressing drugs. Sympathomimetic amines suppress appetite by increasing the availability of norepinephrine in the brain, thus stimulating the CNS. Sympathomimetics fall into 2 groups, amphetamines and non-amphetamines. Amphetamines have a much higher abuse potential than non-amphetamines. The FDA does not recommend or approve amphetamines for either short or long-term weight loss. We usually do not use non-amphetamines for weight loss because of the potential for abuse. If used, they should be used only short-term for 3 months or less. These drugs include phentermine, Adipex, Lamira, Suprenza, diethylpropion, Tenuate, and phendimetrazine, Bontril. Adverse effects include palpitations, tachycardia, overstimulation, restlessness, dizziness, insomnia, weakness, and fatigue. Nursing interventions related to drug therapy. Drugs will not cure obesity. People must understand that without substantial changes in food intake and increased physical activity, they will gain weight when drug therapy is stopped. As with any drug treatment, there are side effects. Careful evaluation for other medical conditions can help determine which drugs, if any, would be advisable for a given patient. Many insurance companies do not cover the cost of weight loss drugs. Your role related to drug therapy is to teach the patient about proper administration, side effects, and how the drugs fit into the overall weight loss plan. Changing drug dosages without consultation with the HCP can have detrimental effects. Stress that diet and exercise plans are the cornerstones of permanent weight loss. Finally, discourage patients from buying over-the-counter diet aids unless recommended by an HCP. Bariatric surgical therapy. Bariatric surgery, surgery on the stomach and or intestines to help a person with extreme obesity lose weight, has become a viable option for treating obesity. Surgery is currently the only treatment that has a successful and lasting impact for sustained weight loss for those with extreme obesity. Criteria guidelines for bariatric surgery include having a BMI of 40 or more, or a BMI of 35 or more, with other significant comorbidities, e.g. hypertension, type 2 diabetes, heart failure, sleep apnea. Most people who undergo bariatric surgery successfully improve their overall quality of life. In addition to losing weight, outcomes include improved glucose control, with improvement of or reversal of diabetes, normalization of BP, decreased total cholesterol and triglycerides, decreased GERD, and decreased sleep apnea. Insurance coverage for bariatric surgery varies. Those who cover surgery often require extensive documentation. This often includes taking part in a supervised weight loss program for around 6 months and a psychologic evaluation. Although overall mortality is very low, several complications can arise from surgery. Therefore, having surgery is carefully considered. Candidates for surgery must be screened for psychologic, physical, and behavioral conditions that have been associated with poor surgical outcomes. These include untreated depression, binge eating disorders, and drug and alcohol abuse that may interfere with a commitment to lifelong behavioral changes. Other contraindications to surgery include illnesses that are known to reduce life expectancy and are not likely to improve with weight reduction. These include advanced cancer, end-stage kidney, liver, and cardiopulmonary disease, severe coagulopathy, or inability to follow nutritional recommendations. Bariatric surgeries fall into one of three broad categories: restrictive, malabsorptive, or a combination of malabsorptive and restrictive. In restrictive procedures, the stomach is reduced in size, less food eaten. In malabsorptive procedures, the small intestine is shortened or bypassed, less food absorbed. Most procedures are done laparoscopically. These patients have fewer wound infections, shorter hospital stays, and a faster recovery period. Restrictive surgeries. Restrictive bariatric surgery reduces either the size of the stomach, which causes the patient to feel full more quickly, or the amount allowed to enter the stomach. In these surgeries, digestion is not altered, so the risk for anemia or cobalamin deficiency is low. The most common restrictive surgeries include adjustable gastric banding and sleeve gastrectomy. Adjustable gastric banding. Laparoscopic adjustable gastric banding, AGB, involves limiting the stomach size with an inflatable band placed around the fundus of the stomach. This restrictive procedure can be done using a lap band or realized band system. The band is connected to a subcutaneous port that can be inflated or deflated by fluid injection in the HCP's office to change the stoma size to meet the patient's needs as weight is lost. The restrictive effect of the band creates a sense of fullness as the upper part of the stomach now accommodates less than the average stomach. The band then causes a delay in stomach emptying, providing patients with further satiety. The procedure can be either modified or reversed at a later date if needed. AGB is the preferred option for patients who are surgical risks because it is a less invasive approach. Because it is restrictive only, patients must follow a strict diet to lose weight and not regain weight. Sleeve gastrectomy, gastric sleeve. In the sleeve gastrectomy, gastric sleeve, about 75% of the stomach is removed, leaving a sleeve-shaped stomach. Although the stomach is drastically reduced in size, function is preserved. Removing most of the stomach results in the elimination of hormones made in the stomach that stimulate hunger, such as ghrelin. Research is ongoing on a new procedure called endoscopic sleeve gastroplasty. It involves using an endoscope rather than making a surgical incision. When the endoscope reaches the stomach, the surgeon places sutures in the stomach, making it smaller and changing its shape. Gastric Application. Gastric Application is a minimally invasive weight loss surgery that reduces the size of the stomach. It is done by folding the stomach wall inward, and then sutures are placed to secure the folded stomach wall. This reduces the stomach volume by as much as 70%. An advantage is reversibility, since there is no gastric resection. Intragastric balloons. Intragastric balloon weight loss systems use a gastric balloon to occupy space in the stomach. The balloon does not change or alter the stomach's natural anatomy. It is designed to help patients feel more full, curb the appetite, and reduce food intake. Patients should follow a diet and exercise plan to help with weight loss efforts. The balloons are less invasive than having gastric bypass surgery. Most are placed endoscopically while the patient is under mild sedation. The HCP places the balloon into the stomach through the mouth. Once in place, the balloon is filled with saline so that it expands. The balloon can be filled with different amounts of saline from 400 to 700 milliliters. With newer balloons, the patient swallows the balloon in a capsule that is attached to a microcatheter. The balloon is inflated with nitrogen gas through the microcatheter. After inflation, the catheter is detached and removed, leaving the balloon in the stomach. When it is time to remove a balloon, It is first deflated and then removed using another endoscopic procedure. Balloons should not be used in patients who have had gastrointestinal or bariatric surgery or who have inflammatory bowel disease, large hiatal hernia, delayed gastric emptying, or active Helicobacter pylori infection. Patients may have vomiting, nausea, abdominal pain, and feelings of indigestion. Other potential risks are gastric ulcers and balloon deflation. Combination of restrictive and malabsorptive surgery. Roux-en-Y gastric bypass. The Roux-en-Y gastric bypass, RYGB, procedure is a combination of restrictive and malabsorptive surgery. The surgical procedure is the most common bariatric procedure done in the United States. It is considered the gold standard among bariatric procedures. Overall, it has low complication rates, has excellent patient tolerance, and sustains long-term weight loss. The RYGB involves creating a small gastric pouch and attaching it directly to the small intestine using a Y-shaped limb of the small bowel. After the procedure, food bypasses 90% of the stomach, the duodenum, and a small segment of the jejunum. A complication of the RYGB is dumping syndrome, in which gastric contents empty too rapidly into the small intestine, overwhelming its ability to digest nutrients. Symptoms can include vomiting, nausea, weakness, sweating, faintness, and on occasion diarrhea. Patients are discouraged from eating sugary foods after surgery to avoid dumping syndrome. Because sections of the small intestine are bypassed, poor absorption of iron can cause iron deficiency anemia. Patients need to take a multivitamin with iron and calcium supplements. Chronic anemia caused by cobalamin deficiency may occur. This problem can usually be managed with parenteral or intranasal cobalamin. Implantable gastric stimulation. An implantable gastric stimulation device, e.g. Maestro rechargeable system, consists of a pacemaker-like electrical pulse generator, wire leads, and electrodes that are implanted in the abdomen. The Maestro system works by sending intermittent electrical pulses to the vagus nerve, which is involved in regulating stomach emptying and signaling to the brain that the stomach feels empty or full. External controllers allow the patient to charge the device and allow HCPs to adjust the device's settings to provide optimal therapy. Adverse events include nausea, heartburn, problems swallowing, belching, and chest pain. Nursing management, perioperative care of the obese patient. Nursing implementation. This section discusses general nursing considerations for the care of the obese patient who is having surgery. Special nursing considerations are described for the patient who is having bariatric surgery. See Chapter 17 through 19 for more on care of the surgical patient. Preoperative care. Special considerations are needed for the obese patient, especially the patient with extreme obesity who is having surgery. Before surgery, interview the patient to identify past and current health information and any assistive devices currently in use, e.g. CPAP for sleep apnea. Comorbidities related to obesity increase the risk for complications in the perioperative period. You may need to coordinate care with the patient's specialists. Have a plan in place before the patients arrive so that they receive optimal care and do not feel like they are a burden to the nursing staff. You must have available appropriate size hospital gowns, beds that accommodate an increased body size, and necessary patient transfer equipment. A larger BP cuff size is needed to avoid measurement errors. Ensure that an oversized BP cuff is available and placed in the patient's room. Consider how the patient will be weighed and transported throughout the hospital. A wheelchair with removable arms that is large enough to safely accommodate the patient and pass easily through doorways should be available. You may need to use alternative assessment techniques to perform assessment of heart, lung, and bowel sounds. For example, because of the large chest wall, breath and heart sounds are often distant. You can use an electronic stethoscope to amplify lung, heart, and bowel sounds. Teach the patient proper coughing and deep breathing techniques and methods of turning and positioning to prevent pulmonary complications after surgery. If possible, show how to use a spirometer before surgery. Spirometer use helps prevent and treat post-operative lung congestion. Practicing these strategies preoperatively can help the patient perform them correct post-operatively. If the patient uses CPAP at home for sleep apnea, make arrangements for the use of a machine while the patient is hospitalized. Excess adipose tissue may make obtaining venous access difficult. A longer IV catheter is helpful, longer than 1 inch, to go through the overlying tissue to the vein. It is important that the cannula is far enough into the vein so it is not dislodged or infiltrated. Special considerations for bariatric surgery. Ensure that the patient scheduled for bariatric surgery understands the surgical procedure. Your teaching depends on the type of procedure and surgical approach. Stress that we will frequently assess vital signs and general assessment to monitor for complications. Tell the patient that they will be assisted with ambulation soon after surgery and encouraged to cough and deep breathe to prevent pulmonary complications. Post-operative care. Initial post-operative care focuses on careful assessment and immediate intervention for cardiopulmonary complications, thrombus formation, anastomosis leaks, and electrolyte imbalances. The transfer from surgery may require many staff members. During the transfer, keep the patient's airway stabilized and give attention to managing the patient's pain. Maintain the patient's head at a 45-degree angle to reduce abdominal pressure and increase lung expansion. The body stores anesthetics in adipose tissue, thus placing patients with excess adipose tissue at risk for resedation. As adipose cells release anesthetics back into the bloodstream, the patient may become sedated after surgery. If this happens, be prepared to perform a head tilt or jaw thrust maneuver and keep the patient's oral and nasal airways open. Diligence in turning and ambulation post-operatively will prevent complications from surgery. The patient will typically begin walking the evening after surgery and then at least 3 or 4 times each day. Assist the patient as needed. The patient may be reluctant to move or may not have the stamina to walk even a short distance. In either situation, you will need help moving an obese patient. Obesity can cause a patient's breathing to become shallow and rapid. The extra adipose tissue in the chest and abdomen compress the diaphragmatic, thoracic, and abdominal structures. This compression restricts the chest's ability to expand, preventing the lungs from working as efficiently as they would otherwise. The patient retains more CO2 with less O2 delivered to the lungs. This results in hypoxemia, pulmonary hypertension, and polycythemia. After surgery, the risk for VTE is increased. Intermittent pneumatic compression devices or compression stockings with low-dose heparin decrease the risk for VTE. Active and passive range of motion exercises are a frequent part of daily care. Wound infection, dehiscence, and delayed healing are potential problems for all obese patients. Assess the patient's skin for any complications related to wound healing. Keep skin folds clean and dry to prevent dermatitis and bacterial or fungal infections. Special considerations for bariatric surgery. Patients have considerable abdominal pain after bariatric surgery. Give pain medications as needed during the immediate post-operative period, first 24 hours. Be aware that pain could be from an anastomosis leak rather than typical surgical pain. Abdominal wounds require frequent observation for the amount and type of drainage, condition of the incision, and signs of infection. Monitor vital signs to help identify problems, such as infection or anastomosis leak. Give room temperature water and low sugar clear liquids as soon as the patient is fully awake and there is no evidence of any anastomosis leaks. Begin with 15 milliliter increments every 10 to 15 minutes. Gradually increase intake to a goal of 90 milliliters every 30 minutes by post-operative day 1. Teach the patient to avoid gulping fluids or drinking with a straw to reduce the incidence of air swallowing. The patient who tolerates clear liquids may begin a low-fat, full liquid diet on post-operative day 3. Ambulatory and home care. Special considerations for bariatric surgery. The patient who has undergone major surgical treatment for obesity has not been successful in the past in following or maintaining a prescribed diet. Now the patient must reduce oral intake because of the anatomic changes from the surgical procedure. The patient must clearly understand the proper diet. A dietitian is usually part of the bariatric team and helps the patient with the transition to the new diet. Patients usually are discharged on a full liquid diet. Then 10 to 14 days after surgery, depending on tolerance, the patient may begin a pureed or soft food diet with vitamin supplementation. Most patients transition to the usual diet 4 to 6 weeks after surgery. The usual diet is high in protein and low in carbohydrates, fat, and roughage. It should consist of 6 small feedings daily. Many need a protein supplement once or twice a day for the first few months after surgery to meet their protein needs. Patient should not consume fluids with meals. Fluids and foods high in carbohydrate tend to promote diarrhea and symptoms of dumping syndrome. Calorie-dense foods should be avoided to permit more nutritionally sound food to be consumed. Teach the patient to eat slowly and stop eating when feeling full. Weight loss is considerable during the first 6 to 12 months. Although behavior modification is not necessarily an intended outcome with these surgical procedures, it becomes an unexpected secondary gain. For example, a person who has had bariatric surgery cannot overeat or binge eat without consequences, e.g., vomiting, abdominal pain. The patient may fail to lose weight if the stomach pouch is too large. An outlet that is much too small may result in the patient losing too much weight. Some patients have been known to overeat when they return home and gain rather than lose weight. Stress the importance of long-term follow-up care, in part because of potential complications. Teach patients to inform the HCP of any changes in their physical or emotional condition. Nutritional deficiencies are expected after malabsorptive bariatric surgery, including anemia, vitamin deficiencies, and diarrhea. Patients should take multivitamins with folate, calcium, vitamin D, iron, and vitamin B12 for life. Peptic ulcer formation, dumping syndrome, and small bowel obstruction may be seen late in the recovery and rehabilitation stage. Several potential psychologic problems may arise after surgery. Assess social functioning, self-esteem, sexual life, and activities of daily living in follow-up care. Some patients feel guilty that they have had to achieve weight loss by surgical intervention rather than by the sheer willpower of reduced dietary intake and exercise. Be ready to provide support and assist the patient in moving away from such negative feelings. By 6 to 8 months after surgery, most patients have lost considerable weight and are able to see how much their appearance has changed. Help the patient adjust to a new body image. Massive weight loss may leave the patient with large quantities of flabby skin, can result in problems related to altered body image. Discuss this possible outcome with the patient before surgery and again during the rehabilitation phase. Cosmetic surgery may alleviate this situation. Do not hesitate to encourage counseling for unresolved psychologic issues. Often one result of bariatric surgery is the return of fertility in women. Pregnancy complications can result from anemia and nutritional deficiencies. Furthermore, depending on the type of surgery, intestinal obstructions and hernias may occur with pregnancy. Women must carefully consider the risk for pregnancy after bariatric surgery. In general, encourage women to postpone pregnancy for 12 to 18 months after bariatric surgery. Evaluation. The expected outcomes are that the obese patient will have long-term weight loss, have improvement in obesity-related comorbidities, integrate healthy practices into daily routines, monitor for adverse side effects of surgical therapy, have an improved self-image. Gerontologic considerations. Obesity in older adults. The prevalence of obesity is increasing in older people. The number of obese older persons has markedly risen because of increases in both the total number of older persons and the percent of the older adults who are obese. Obesity is more common in older women than in older men. A decrease in energy expenditures is an important contributor to a gradual increase in body fat with age. Obesity in older adults can worsen age-related declines in physical function and lead to frailty and disability. Obesity is associated with decreased survival. Those who are obese live 6 to 7 years less than people of normal weight. Obesity worsens many changes associated with aging. Excess body weight places more demands on arthritic joints. The mechanical strain on weight-bearing joints can lead to premature immobility. Excess intra-abdominal weight can cause problems with urinary incontinence. Excess weight may contribute to hypoventilation and sleep apnea. Obesity affects the quality of life for older adults. Weight loss can improve physical functioning and obesity-related health complications. Same therapeutic approaches for obesity discussed earlier also apply to the older adult. Cosmetic surgical therapy. Lipectomy. Lipectomy, adipectomy, is done to remove unsightly flabby folds of adipose tissue. There is no evidence that regeneration of adipose tissue occurs at the surgical sites. However, stress to the patient that surgical removal does not prevent obesity from recurring, especially if lifetime eating habits stay the same. Although body image and self-esteem may improve with such procedures, these operations are not without complications. Do not underestimate the dangerous effects of anesthesia and the potential for poor wound healing in the obese patient. Liposuction. Another cosmetic surgical procedure is liposuction or suction-assisted lipectomy. It is used for cosmetic purposes and not for weight reduction. This surgical intervention helps improve facial appearance or body contours. A good candidate is a person who has achieved weight reduction and has excess fat under the chin, along the jawline, and the nasolabial folds over the abdomen or around the waist and upper thighs. A long, hollow stainless steel cannula is inserted through a small incision over the fatty tissue to be suctioned. This surgical procedure is not usually recommended for an older person because the skin is less elastic and will not accommodate the new underlying shape. Metabolic syndrome. Metabolic syndrome is a group of metabolic risk factors that increase a person's chance of developing CVD, stroke, and diabetes. About 1 in 3 adults have metabolic syndrome. The syndrome is more prevalent in those 60 years of age and older. Metabolic syndrome is a cluster of health problems including obesity, hypertension, abnormal lipid levels, and high blood glucose. Metabolic syndrome is diagnosed if a person has 3 or more of the conditions listed in Table 40.12. Etiology and Pathophysiology. The main underlying risk factor for metabolic syndrome is insulin resistance related to excess visceral fat. Insulin resistance is the decreased ability of the body's cells to respond to the action of insulin. The pancreas compensates by secreting more insulin, resulting in hyperinsulinemia. Other characteristics include hypertension, increased risk for clotting, and abnormalities in cholesterol levels. The net effect of these conditions is an increased prevalence of coronary artery disease. Clinical manifestations and diagnostic studies. The signs of metabolic syndrome are impaired fasting blood glucose, hypertension, abnormal cholesterol levels, and obesity. Medical problems develop over time if the condition is not addressed. Patients with this syndrome are at higher risk for heart disease, stroke, diabetes, renal disease, and polycystic ovary syndrome. Patients who have metabolic syndrome and smoke are at an even higher risk. Nursing and interprofessional management, metabolic syndrome. There is no specific management of metabolic syndrome. Interventions focus on reducing the major risk factors of CVD and type 2 diabetes, reducing LDL cholesterol, stopping smoking, lowering BP, losing weight, and reducing glucose levels. There are no specific medications for metabolic syndrome. Patients receive cholesterol-lowering and antihypertensive drugs as needed. Metformin glucophage can lower glucose levels and enhance the cell's sensitivity to insulin. Obese patients may be candidates for bariatric surgery. For long-term risk reduction, the person needs to maintain a healthy weight, increase physical activity, and follow healthy diet habits. You can help patients by giving information on healthy diets, exercise, and positive lifestyle changes. The diet, which should be low in saturated fats, should promote weight loss. Weight reduction and maintaining a lower weight are a priority in those with abdominal obesity and metabolic syndrome. Because sedentary lifestyles contribute to metabolic syndrome, increasing regular physical activity will lower a patient's risk factors. In addition to helping with weight reduction, regular exercise decreases triglyceride levels and increases HDL cholesterol levels in those with metabolic syndrome.